Thanks. So yeah, I do work in a few different fields, HIV, especially looking at how HIV risks among people who inject drugs, but I also look at drug policy. And today, the focus of the talk is really going to be about drug policy, because there's one of the main issues that we're dealing with right now, as I'm sure you guys know, is overdose related to adulterated supply of street drugs. So I'll get into that a little bit, and hopefully there'll be time for questions at the end. So, I don't have to, I think, at this point, reiterate how much of a massive deal this is. There's so much media attention, and I think rightfully so, on the fact that we've got skyrocketing overdose death rates. I think one thing to think about when you see media reporting around what people are calling the opioid crisis, is to think in your own mind, okay, well, are we talking about an overdose crisis, which is related to adulterated supply, like super potent opioids? Or are we talking about an opioid crisis where more and more people are using opioids? And those are really distinct issues that often get conflated, particularly in the media. But just for today, just to keep things simple, I'm going to be talking about overdose related to opioids, not necessarily opioid dependence on its own. So one interesting thing that's, I think, worth noting is that there's been this trend. Basically, for 50 years, there was a trend where there were fewer and fewer people. This is data from the US, but data from Canada are really similar. There were fewer and fewer people reporting that they were using heroin as their first opioid of abuse. So heroin is an opioid just like morphine or fentanyl, which we'll get into, anyway, lots of over-the-counter formulations of opioids as well. What we're seeing here, though, is that for the first time in the mid-2000s, we saw an uptick in the number of people stating that they used heroin as their first, the first opioid that they used sort of non-medically, and a reduction in the number of people who reported that they used a prescription opioid as their first non-medical opioid. Now, why is that important? Because I think it speaks to a larger kind of population shift in what's happening with the populations at risk of using or experiencing harms related to opioids. That is sort of like the backdrop here. So when people are talking about this overdose crisis, it really is reflecting something new that we haven't seen in like 50 years, which is related to these larger population trends shifting. So it's actually, it's sort of mind-boggling how many people are dying right now of opioid overdose. In 2015, the estimate was that there were 65,000 people who were going to die in the States. I think that was actually surpassed in the final numbers. And in Vancouver, which has been particularly hard hit, this is like a small town. This is a town compared to Toronto that's maybe a quarter the size, less than that. And yet they're on pace for at least 1,400 overdose deaths by the end of the year, which is really, really scary. Now, at the same time, I think it's important, what gets lost in this conversation around risks related to drug use is that there are still these other concerns related to the use of opioids that go beyond overdose. So here you can see that there are still lots and lots of people internationally, millions, who use drugs by injection and who are HIV positive. And Canada, while not a country with the highest level of HIV prevalence among people who inject drugs, is certainly not the lowest. So estimates are that there are 15 to 20% of people who inject drugs in Canada who are HIV positive. Now, just getting back to this whole issue around opioid overdose, lots of what's driving this is the presence of a toxic drug supply. So people are using, I'm sure, you put up your hand if you've heard of fentanyl. Right. So fentanyl is a super potent opioid. It's 50 to 100 times more powerful than morphine. Morphine is pretty much equivalent to heroin. So what we're seeing is a shift towards a street drug market that is increasingly composed of fentanyl rather than less potent opioids. And that is problematic. And in a lot of ways, that's what's driving overdose, because the more potent the opioid, the higher the risk of overdose. And this, I think, can really be traced back to over a century now, basically 150 years of an over-reliance on supply reduction as a way to prevent people from using drugs. So if you look at the budget in Canada and the US, in most major countries, the majority of the budget for drug prevention or sort of a drug policy is devoted to enforcement and supply reduction. 10 years ago, some colleagues of mine did an analysis that almost, I think, 90% of the total drug policy budget in Canada was related to law enforcement. So, this is like a vast, just a massive prioritization of law enforcement over other ways of preventing people from using drugs. This is also not just in North America. This is a situation where it's not just the US and a war on drugs, and because we happen to be next to the States, we're also sort of oriented towards law enforcement and supply reduction. This is really kind of the accepted approach, is that you really front load your drug policies with law enforcement, and then everything else comes after. The issue, though, is that when you're pushing against a drug market, the drug market has to create efficiencies. So using law enforcement to combat international drug trafficking makes drug traffickers more efficient in what they're doing. And that's why we've moved, I think, from what a lot of people have been considering a crisis of drug use, I would argue is really a crisis of contamination. Because this is, again, thinking about the difference between overdose and like opioid overdose related to highly potent opioids and opioid dependence, right? These are two separate things. And what we're seeing is, yes, there's been some fluctuation in the number of people who are using opioids, but there's been a massive skyrocketing increase in the number of people who are dying of opioids. So we need to separate out this idea of sort of use of all drugs as the problem and focus more specifically on what is driving the particular risk of overdose right now. And that's why I would describe this as a crisis of contamination, because we've got a street drug supply that is now so potent that it is toxic. And it's basically been contaminated. Interestingly, this crisis, while different for the some of the reasons that I've outlined, has similar roots in other epidemics that have faced people who use drugs. So, an over-reliance on law enforcement and supply-side strategies has resulted in people who inject drugs not wanting to access services like clean needles or injecting equipment, not being able to inject in safe environments, sometimes sharing syringes, and that leads to an increase in HIV and hepatitis C infection. When people rush injections because they're scared that they're going to be arrested, they might jam a needle in, or they might not be able to use clean water, and then they can open themselves up to abscesses, infections, cellulitis, septicemia, all these nasty conditions. It's also related to the fact that because drug use has been so stigmatized through criminalization, that we basically have this epidemic of untreated mental illness. Substance use disorder is a mental illness, and because of the criminalization of drugs, though, it's really, really difficult to connect people who are experiencing substance use disorders with the kind of treatment that we know works. And I would say that this crisis of contamination has also resulted from, it's basically an inevitable result of intervening on one market without recognizing that this market is linked to a bunch of other markets. So what do I mean by that? Well, in Canada, for instance, we have a number of different markets. We have a regulated market for drugs. So that's drugs like alcohol, tobacco, cannabis is soon going to be regulated. We have a prescription market of drugs. So that's drugs like fentanyl, prescription fentanyl, OxyContin, Oxyneo, drugs like that. We also have a diverted market. So this is sort of what people sometimes call a gray market, which is where these prescription drugs are diverted and then used non-medically. And then we have an illegal drug market, which is fed basically by this illegal street drug supply. Cocaine, MDMA, ecstasy, heroin, and now street fentanyl. The issue is that if you intervene on one of these markets without considering, basically if you intervene on one of these markets, it's going to have a ripple effect across all the other markets. So I'm not sure how much you guys are familiar with this, but OxyContin was a drug that was introduced as a really effective way to treat pain because it was believed to not really be addictive. Unfortunately, that was a fraudulent claim that the pharmaceutical company, Purdue Pharma, that produced this drug had made. And what that resulted in was this massive increase in the availability of prescription opioids. And then governments, when they recognized this, tried to reduce access by clamping down on the prescription market. But when you have a population of people who are addicted to a particular kind of drug, like OxyContin, and then you just stop the supply of that drug without putting in components that allow people to be connected to treatment, you have a large population of people who now require this drug, or else they're going to go through physical withdrawal, and nowhere to get it other than the street drug market. So you can see how intervening on one market without considering how all the other markets are going to be affected can really create problems that are really hard to anticipate and respond to. The other thing that I would mention, just going back to this idea of sort of incentivizing efficiency in the drug market. Every time that there are supply-side attempts at reducing supply, it incentivizes drug markets and drug traffickers to become more efficient. And in the context of a drug market, efficiency is the same as potency. So you think about if street fentanyl is 100 times more powerful than heroin, then if you've got this much heroin and this much fentanyl, like which one is more efficient? Because we're talking about people at its basic root, or at its basic root, distributing materials across borders, right? So when you're thinking about that, you're trying to make your package as undetectable as possible. If you can fit 100 times more drugs in the same package, that's super efficient. And that's why we've been seeing this increase in the efficiency, which is basically the potency of drugs in the opioid market. And this is predictable because this has been going on for, like I said, 100, 150 years. Opium is the basic drug that is produced from the opium poppy. And that was the first drug that was the opioid-based drug that was distributed and trafficked internationally. Then, when there were concerns around opium, laudanum was introduced, which was also an opioid, which was more efficient. Then, after there was a crackdown on laudanum, heroin, which was actually produced by a pharmaceutical company, but then discontinued because it was found to be super addictive, was produced by drug traffickers because it's so much more potent and therefore efficient to transport compared with opium. Then fentanyl, because fentanyl is more efficient to transport than heroin. Now we're hearing reports of carfentanil, which is magnitude times greater potency than fentanyl. And you can just see how this cycle continues. So, people often ask me, is fentanyl here to stay? I don't really see, if you look at the history of illegal drug trafficking, you don't really see the market moving backwards in terms of efficiency. And you don't really see that in any market. Think about the iPhone market. They're not going to come out with the next iPhone, which is not as good or slower or larger or bulkier than the last iPhone. It's just not the way that markets work. And this illegal drug trafficking market abides by the same rules as any other economic market. Now, the one thing that people point out, say, well, what if fentanyl is killing so many people that that introducing it is going to reduce the market share? And I would say that at this point, that is definitely a valid argument, and that could be the case. But at this point, we have not seen any kind of movement suggesting that levels of fentanyl trafficking are lowering as a result of people dying. So, unfortunately, it seems like if left unchecked, if we do not intervene on the drug market, fentanyl, these super high potent opioids, are going to be the new normal, which is obviously really, really disturbing when you think about how many people are at risk of dying. That being said, there are some non-dynamic drug markets. So, think about the illegal drug market. Like I said, it's always getting more efficient. It's always moving in a way that increases potency, that's trying to get around law enforcement and supply reduction strategies. But there are some drug markets that are non-dynamic. So alcohol, not dynamic. If you go to the liquor store, which obviously none of you guys do, right? It's the same product every time you go. And every time you go in, there will be a little bit of variation. There will be some different products that are introduced, but they all, it's not like every month you go to the liquor store and everything has, every product has increased in alcohol content by 10%. It's really static. Same thing with tobacco. The level of nicotine, tobacco, is really constant. The pharmaceutical sort of market, the prescription market, it's a bit more dynamic, but it's also really controlled. There are regulated doses for everything. And in fact, that's one thing that is consistent across all these markets, is that there are regulated doses, and that we know that the product that you're buying, that the dose of the drug in that product is going to be the same as what's on the label, and that you will be able to consistently access it. I would also point out that in Western Europe, there is an illegal opioid market. People use heroin there, they use other opioids, street opioids, but for whatever reason, they aren't subject to the same intense dynamic efficiency increases in potency that we've seen in North America. So, do you guys all know what a supervised injection site is? Okay, so it's a place where people who use drugs non-medically, illegally, can go and can inject drugs under supervision by medical professionals. So they opened a supervised injection facility in Paris last year. I went and visited it, and Paris is obviously a huge city. Lots of people using drugs, opioids by injection there. They had been open 8 months, and they had had 4 overdoses in 8 months in Paris. Now compare that with what we've heard in the supervised injection facility in Paris. Compare that with what we've heard from places like Vancouver, where in one day last year, there were 40 overdoses. So there's something about the market there that is totally different. And when I asked what it was, the people there said that there was this drug called Skenon that people used, which was basically prescription. It was a diverted prescription opioid. It was prescription morphine in a powder that people used non-medically, and it was basically in the drug market there. It was widely available and it was a consistent dose. So people always kind of knew what they were injecting. So the level of overdose risk went way, way down. So going back to this, if it's not now, if we've moved beyond this idea that it's just a crisis of everybody using drugs and that's a problem, but really understanding more that what we're talking about is a crisis of contamination of the street drug supply, which is increasing the risk of people who use drugs. Well, how do you treat contamination? Obviously, supply has overwhelmed our drug policy, our interventional levers, the way that we've historically tried to manage the illegal drug market to prevent drugs from entering the country. That has been totally overwhelmed. And without that, I think, it sort of feels like, well, what else can we do? Because that's, this hammer of supply reduction and law enforcement is sort of the only tool that we've been wielding. But I would say that there is a playbook. We just have to move from our thinking around drug policy and consider analogous situations. There are protocols that exist in the world that have been developed to address contamination. So here's the title page of a report from the U.S. Environmental Protection Agency about what you do when your water supply has been contaminated. And it's really interesting. And in a lot of ways, it applies almost perfectly to the situation that we find ourselves in with the illegal drug supply. There's, these decision trees. It's a very sophisticated set of responses that can help guide policymakers to try to prevent contamination from killing people and to try to reverse contaminations when they happen. So there's 4 basic steps. First thing you need to do is communicate the risk. You have to say, okay, this supply has been contaminated, so that people who rely on that supply can take steps to make sure that they don't get poisoned. Second step is for those people who have been poisoned to treat them as quickly as possible. The third step is to remove the contaminants or the contaminated parts of the supply. And the fourth step is to replenish the supply with non-contaminated products. Seems straightforward. This happens all the time. Water supplies get contaminated, protocol gets established, and it gets cleaned up. So how do we do that, though? Obviously, it's a bit harder when the supply is an illegal drug market. But there still are ways that we can go through using this protocol to try to prevent people from dying. And at this point, if you have moral concerns around enabling drug use, I think that we can all just set those aside and can happily discuss them after we stop people from dying. I think we can all agree on that. So, step 1, communicate risk. Well, the first thing that we need to do is to engage with people who are relying on the supply. So that's people who use drugs, who use street drugs. And what evidence has shown is that if you're trying to create messages and communicate information to people who are using this supply, then the best way to do that is to work with people in that community, just like any situation. If you can work with people to communicate risk in language and in ways that make sense for that population, then you're going to be ahead of the game. So this knowledge has to be based around peer knowledge about what constitutes risk. It's got to be reliable and trustworthy. And this is, I think, really important because the government actually does not have a great track record of communicating reliable and trustworthy information around drugs because of the fact that it's been illegal and stigmatized for so long. And we got to think about, removing the whole moralizing thing. If there is one supply of water in a town and somebody drinks it and they get poisoned, we don't say to them, well, it's your fault that you drank the poisoned water. That's just not the way it goes. Part of that is because we recognize that there are structural constraints. If there's only one supply, if they rely on it, and if they don't have access to any other ways of accessing, let's say, water in this case, then of course they're going to drink from it. And we have to think, I think, structurally, in the same sort of structural sense, when we're thinking about why people why people continue to access a poison supply of street drugs. I think the same sort of structural constraints are in place. Second step is to treat poisoning. So in the case of when people are poisoned with opioids and go and start to overdose, there are all these really effective approaches that can be done for pretty cheap to make sure or try to prevent them from dying. So the first thing you do is provide oxygen. I'm not like a paramedic, so I can't go through every single, but I'm sure there are people here who know. But basically, oxygen is a great way of doing it. There are basic EMS procedures. There's also this drug called naloxone, which you can inject into somebody's body. It doesn't have to be into their bloodstream, which immediately interrupts the receptors in the brain that absorb opioids. And you can immediately prevent people from overdosing. Interestingly, naloxone, really effective. You can just give one shot if people are overdosing with heroin. But with fentanyl, because it's so powerful, reports are, like if you talk to people who are running the overdose prevention site in Moss Park, that sometimes people need like 2 or 3 hits of naloxone, which is really scary. You can also make sure that people have medical attention or are injecting or using drugs under medical supervision. So this goes back to the supervised injection model, where people enter a room, there's medical staff present, and they're able to be attended to if they do indeed start having complications from the toxic drug supply. And all of this, though, means connecting with hidden populations. So people who are tough to find, people who are street involved, who don't like to access services for whatever reason. Treating poisonings means making sure that people aren't injecting alone, that they are connected with services, and to do that, we need to make sure that those services are really low threshold, that it's super easy for people to know where they are, to access them, to not be made to feel basically like an asshole when they're there. Step 3 is to remove the contaminants from this drug supply. And one really interesting way of doing that is through an emerging intervention called street drug checking. It's really simple. Hospitals like this have super expensive equipment called mass spectrometry machines that you can basically put a sample of any chemical in and it'll tell you what's in it. So good news, we heard today actually, Health Canada is going to fund a street drug checking program in Toronto. So people who show up to the supervised injection facilities that are being established in Toronto can provide like a tiny little sample of the drugs that they want to use. We'll run them to the labs at St. Mike's and a few other hospitals in town, and we'll be able to tell people exactly what's in that drug. So then people can make a really informed choice about whether they're going to use that drug, if they are going to use that drug, how much they're going to use, if they are going to use, and they know how much, in what environment they're going to use it in, to make sure that if they do overdose, they have access to medical supervision and naloxone. And this is kind of like a jargony term, but we're talking about risk competency. And I think that's really important because for so long the discourse has been around, well, people make decisions and they make decisions because they're not being rational or they're dumb or they don't know what they're talking about. Whereas I think, if a lot of the decision making that happens around risk happens because sometimes people just don't have enough information or enough resources to competently manage risk. And that's not their fault necessarily, but programs like street drug checking can increase people's risk competency so that when they're presented with situations, they're able to make more informed choices. Step 4. So we've got, I think from up until now, it all seems relatively doable. Step 4, replenish supply, is definitely the hardest. So I would argue that it's not enough, steps 1 to 3, it's not enough, even if we completed those and everything was great, we would still see this rash of overdose. Maybe not everybody would die, but everybody, if there's still super potent toxic opioids in the supply, we're going to see lots and lots and lots of overdose. And even non-fatal overdose, even if people don't die from overdose, we really should be trying to prevent people from overdosing in the first place. So while I said that fentanyl is probably here to stay for the reasons I mentioned, I also don't want you guys to get the sense that, that's just fine, like it's business as usual and we're just going to have to deal with it. When I know water supply is tainted, people don't say, well, okay, I guess, all the water's poison now, and then walk away and just sort of live their lives. No, we try to deal with the contaminated supply and replenish it with non-toxic supply. Now remember, the alcohol market, the tobacco market, these are really static markets. And I think the way that we can replenish the supply, when we're talking about the illegal opioid supply here, replenish it with non-toxic opioids, we're really talking about introducing the same kind of stasis into the opioid market as we see in the alcohol and the tobacco market. So how do you do that? Well, it's tough, right? It's an illegal drug supply. We're not very good at intervening on the illegal drug supply. That's how we got to this in the first place. But there are ways to get people who use street opioids like fentanyl to shift from a reliance on the street drug supply to a reliance on a supply of opioids that are sort of that are first of all regulated, that are clinically appropriate, and that bring them into a system of care. And so there's this model of care for people who are dependent on opioids called medication-assisted treatment, or opioid agonist therapy. The terms are always changing, and I can't keep up. Anyway, the point is that what you're doing is you're treating people's opioid dependence basically by using opioids. So rather than have someone use heroin or use fentanyl, you can have people enrolled in a methadone program. Methadone is an opioid. Or a buprenorphine program. Buprenorphine is an opioid. Or a formulation like Suboxone, which has one of these opioids along with naloxone, that drug that I mentioned before, that you can inject into people to reverse opioids. There's also, this might seem crazy, prescription heroin. So people who are really opioid dependent try to go on methadone, try to go on Suboxone. It doesn't always take. But there's an emerging treatment modality that's been around for decades now in Europe, but is just starting in Canada, where people who are super opioid dependent are provided with pharmaceutical grade heroin in a managed dose. They know exactly how much. It's the same dose every time. And again, this is, I think, the important thing to remember. You're thinking about how to prevent overdose, given the toxicity of the illegal drug supply. People are prescribed a measured dose of pharmaceutical grade heroin, and it's been shown to dramatically reduce people's risk of overdose, also help people manage their dependence stop relying on a sort of the street economy, and help people just generally improve their health and social well-being. These are all super useful and evidence-based approaches that we know can help reduce people's risk of overdose and help reduce their reliance on an illegal drug supply that at this point is super toxic. They're also all standard dose opioids. So what we're doing is we're kind of getting rid of the craziness factor where people don't know what crazy drug they're going to be injecting because the illegal drug market is so dynamic, and replacing it with a standard dose regulated market that they can rely on. Just like, you buy a 2% beer. Of course you guys don't because you're so young. But you buy a beer, it's 2%. I guess that's a pretty weak beer. But you know that if it says 2% on the label, that's how much alcohol is going to be in it. And that's the kind of system that I think we need to bring to the illegal drug market. Now, I just want to mention that this all, I think, makes sense. I mean, definitely makes sense to me, and I hope I've convinced you guys that it makes sense also. But there are major barriers to making this sort of the standard of care and the standard of response to this issue. And those barriers are basically stigma around drug use, scaling up these interventions, like making sure that supervised injection facilities, that naloxone, that street drug checking, that medication-assisted treatment or opioid agonist therapy, whatever you want to call it, are available to everybody who needs it. And finally, political will. And I would say here that 2 and 3 are really dependent on 1. And the issue here is that it's a bit complicated, but basically stigma led to the criminalization of drugs, and stigma and the criminalization of drugs reinforces stigma. Now that would be okay if the criminalization of drugs resulted in the kinds of outcomes that we're interested in seeing. But the fact that the criminalization of drugs has basically resulted in this massive spike in people dying, I think is sort of hints that we might need to look at a different approach. And while the federal government is generally on board, kind of, they've been really sending mixed messages. So the federal government has been saying, in response to this overdose crisis, stigma is bad. Stigma kills. We need to stop people feeling stigmatized around drug use and opioid use, because when people feel stigmatized, they're not going to access services. They're going to use alone. They're not going to be able to manage their drug use through accessing other alternative sources like methadone or prescription heroin. But the federal government also says we will not consider decriminalizing drugs other than cannabis. So here, health minister says overdose issue requires treatment without judgment. So basically, we cannot treat people who are addicted to opioids. We can't judge them for their use. Now, so the former federal Minister Fell said it includes every Canadian looking at this problem for the health problem that it is and addressing stigma and discrimination associated with substance dependence. But the federal government, on the other hand, says that, they're not going to consider even decriminalizing illicit drugs, which is problematic because, as a colleague of mine found out when she asked the health minister this point blank, they don't really have an answer for how to reduce stigma if you still got a system of criminalization. So Nasli, who I work with, asked the minister, said, I really see criminalization as systemic stigmatization, institutionalized stigmatization. I mean, how can you stigmatize something more than by making it illegal? And so she basically said, well, how can you destigmatize something if you don't decriminalize it? The minister didn't have an answer. And this is really at the heart, I think, of the lack of response that we're seeing. I would also say, though, that we're not nowhere, and that we're actually, when we think about the kinds of pieces and the system of care and response to drugs that we would like to see in place, we're kind of actually already halfway there. And here, halfway there means halfway to a regulated system for illegal opioids. We've got heroin prescription, which basically says, here's some heroin. You will be able to use it under medical supervision. It will be provided on a prescription basis for free. We have medication-assisted treatments like methadone, buprenorphine. These are also opioids. We have supervised injection facilities, which are sites within which the Controlled Drugs and Substances Act does not apply. So we have like these micro sites where drugs are not illegal. We have street drug checking, which provides people with an information about what kind of dose they're using, sort of like providing people with a label of how much alcohol content there is, or in this case, how much opioid content there is in their drugs. This is all sort of adding up to a de facto micro-regulatory system for opioids. And I would also say that, it's important to remember that when we think about how we're going to approach regulating drugs, every system is different. So providing people with prescription heroin, this happens within a clinical setting. A doctor prescribes it to a patient. Generally, the patient is observed while they're doing it. This is so different than regulating recreational cannabis use, which is going to resemble something more like our system for alcohol. So I think we need to move out of the kind of idea that all these regulatory structures are going to look the same. And in fact, what we're going to look at is sort of these individualized systems of regulation for all these different drugs. And this all means that we need to confront where our policies are taking us. If we're already kind of halfway to regulating opioids, then let's have that conversation. Let's figure out what that means and get ahead of it so that, when it actually happens, we've been able to meaningfully put in place what we want in place. I think I'll just end it there because, it's been long. But yeah, I think hopefully that's helpful for you guys, and I'll take questions.